In this section, we'll talk about the role of blood pressure control in the management of ischemic stroke, particularly in the acute period. As some background, I just wanted to show you a little bit about cerebral autoregulation. The body's actually pretty smart, so you can see on the graph that whether you're normotensive or hypertensive, that your blood pressure can vary a little bit below or a little bit above your normal and still maintain a good plateau of cerebral blood flow as shown here by this arrow. The problem is that when your blood pressure gets very high above your normal or very low, which is more worrisome, that your cerebral blood flow starts to fall off that plateau and you can see it start to decrease. And although we don't directly measure cerebral blood flow in practice, hopefully you can just get the theoretical issue here is that when it gets too low, and that's a cerebral blood flow less than 20, you start to get ischemia in the cells, and then below 12 is when you actually get infarction or cell death. So the goal when we're talking about blood pressure management is whether somebody's normotensive or hypertensive at baseline, you want to try and keep them on that plateau when controlling their blood pressure and prevent any large drops in their mean arterial pressure, which corresponds to a drop in cerebral blood flow as well. So, in the acute setting for stroke, as I mentioned, blood pressure management is really important. And as we'll talk about, both having high and low blood pressure can be bad in patients who've had a stroke. On the one side, if your blood pressure is too low, this can decrease your cerebral blood flow. And you actually see patients who've had a stroke that naturally their blood pressure typically increases so that you have a systolic greater than 160 in about 60% of your stroke patients. And this is just a natural protective mechanism that your brain does to help maximize blood flow in the acute setting of stroke. You'll see that within the first 24 hours, the blood pressure tends to naturally go down on its own, typically by about 30% as things equilibrate. On the flip side, if your blood pressure is too high, as we discussed previously, it increases your risk of cerebral hemorrhage. So you want your blood pressure kind of in a sweet spot in the middle. The question is, what is it? Unfortunately, based on studies done in stroke patients, we really don't have a specific target blood pressure for the acute period. In addition, we don't really have the studies to point us towards any specific agent as far as superiority for the management of acute stroke. So understanding the pharmacology and the different effects of the agents will help you select the most appropriate one for your patient. In the acute setting of ischemic stroke, you're often faced with the need to rapidly get your blood pressure to your goal. And so if you remember back from physiology, blood pressure is comprised of cardiac output and your systemic vascular resistance. So if you can lower either your cardiac output or your systemic vascular resistance with a medication, that should help decrease your blood pressure. Cardiac output is also comprised of stroke volume and heart rate. So again, if you can decrease either your stroke volume or heart rate, that should decrease your cardiac output. So what do we have available for us? So hopefully this is a little bit of review from back when we talked about anti-hypertensives in the fall. But if you remember, beta blockers, for example, beta-1 selective agents like esmolol are going to act more specifically on decreasing cardiac output. Agents that would more directly target systemic vascular resistance would be something like your dihydropyridine calcium channel blockers, and the one we'll talk about today is nicardipine. There are also vasodilators such as nitroprusside and nitroglycerin. These will vasodilate and decrease your stroke volume, which should then decrease your cardiac output. And then you also have mixed agents. There's beta blockers like labetalol that block both alpha and beta. So these not only decrease systemic vascular resistance, but can also decrease heart rate and cardiac output. The first agent we'll talk about is called nicardipine, or the brand name is Cardine. Again, this is a dihydropyridine calcium channel blocker, and it works just like the rest of them in that it binds to the calcium channel and prevents the influx of calcium into the cell. So that prevents smooth muscle contraction, and the net result is that you get vasodilation. If you look at the effects of nicardipine as compared to the other calcium channel blockers, you can see here that nicardipine is very potent for causing vasodilation. It's very selective for vascular smooth muscle, so it causes vasodilation both systemically and also in the coronaries, but it has very minimal effects directly on inotropy and AV nodal conduction, which differs from the non-dihydropyridines like diltiazem and verapamil. So for a patient with hypertension that you need to control, an agent like nicardipine is very useful. Similar to other dihydropyridines, nicardipine is indicated for patients with chronic stable angina. This is what we reviewed back in the fall. The reason why dihydropyridines like nicardipine are useful for patients with angina is again because they cause systemic vasodilation to decrease oxygen demand, and they also can cause coronary vasodilation to increase supply. So all this helps decrease anginal chest pain. What we're focusing on here is its role in hypertension. There are both oral and IV formulations of nicardipine, but the intravenous formulation is again what's typically used for management in the acute setting. Nicardipine is actually one of the few IV antihypertensives that has some data specifically in patients with stroke, and it's now considered the first-line agent for ischemic stroke patients because in studies versus labetalol, it's been shown to get blood pressure under control faster with less variability and less need for adding on additional antihypertensive medications. Kinetics-wise, because nicardipine does come orally and IV, there are some issues with bioavailability, but I'll say in practice you don't see oral nicardipine very often, so I really just draw your attention to some of the IV kinetics. If you look at the onset, it's relatively quick, about less than 10 minutes. However, if you compare this to some of the other antihypertensive agents we'll look at in a few minutes, such as nitroprusside, nicardipine is actually a little bit on the slower side for onset. Duration is moderate, so after you discontinue, it takes about 40 to 60 minutes for the effects to wear off. Adverse effects of nicardipine are mostly related just to the therapeutic effects of the drug, so vasodilation is commonly associated with headache, hypotension, and reflex tachycardia. Peripheral edema has also been reported similar to the other dihydropyridines. Another class of antihypertensives that's used in the blood pressure management of acute ischemic stroke are beta blockers. As you've reviewed before, beta blockers block activation of adenyl cyclase via the stimulatory G protein. This reduces the production of cyclic AMP and phosphorylation of this calcium channel, which results in a decreased entry of calcium into the cell. And this results in the net effect of beta blockers, typically of vascular smooth muscle relaxation. As you've reviewed before, beta blockers have tons of clinical uses, and we'll be talking about its role in hypertension. I'm just going to focus on the intravenous beta blockers that are available. The first one is esmolol, and this is a beta-1 selective blocker, so its primary effects are to decrease blood pressure and heart rate. Labetalol is a mixed antagonist. Labetalol is a mixed antagonist, and it blocks both beta-1, beta-2, and alpha receptors, and it's also a partial beta-2 agonist. So its effects are several. Via the beta-1 blockade, it decreases blood pressure and heart rate, and via its alpha effects and beta-2 effects, it causes arterial vasodilation. Kinetically, both are available IV, as we mentioned. Labetalol is also available orally. Again, we're going to focus on the IV properties of these agents. So if you compare the two, esmolol has actually got a faster onset and a shorter duration than labetalol does. So esmolol is really just used as a continuous infusion. Labetalol has a fairly short onset of action and a little bit longer duration of action as well, which makes it a useful agent for bolusing. It can also be given as a continuous infusion. One thing to note about labetalol is that this duration of about 3 to 6 hours is what's typically reported with single doses. As you start to get multiple IV doses of labetalol, the duration actually extends somewhere up to 16 to 18 hours. And for this reason, labetalol is not as easily titratable as esmolol because of the longer offset. As a review of the adverse effects of beta blockers as a class, the most common is just exaggeration of their normal cardiovascular effects. This would include things like excessive hypotension, bradycardia, sometimes heart block, and negative inotropic effects. Angina may occur, and this is typically in the setting when beta blockers are abruptly discontinued, and this is just due to increased sensitivity of the beta receptor when patients are on chronic therapy. Other non-cardiac adverse effects can include bronchospasm, This may be lessened by using beta 1 selective agents. Some of the more lipophilic beta blockers can cause more of the insomnia, depression, and fatigue. You can also get changes in the lipids, and all the beta blockers may blunt recognition of hypoglycemic effects. Drug interactions, the main ones to worry about are other agents such as the non-dihydropyridine calcium channel blockers or other antiarrhythmics that may block the AV node. In addition, because of the antihypertensive effects, combination with other agents that decrease blood pressure can cause additive effects. So we talked about that beta blockers have a lot of clinical uses outside of stroke. What are their role in the setting of stroke? As we mentioned, based on the pharmacological properties, labetalol is typically used as a bolus to rapidly get the blood pressure under control. As a drip, it's less utilized just because of the longer offset compared to esmolol and nicardipine. So it's typically reserved after nicardipine or esmolol for maintenance therapy with the drip. Esmolol is probably considered a second-line agent to nicardipine. It is rapidly titratable, but again, nicardipine has a little bit better evidence for getting blood pressure rapidly under control. And you also have to consider in patients who present with bradycardia or may have decreased left ventricular function, like a heart failure patient, that use of a beta blocker may not be indicated because of the negative inotropic effects. Moving on, IV hydralazine is another option for the management of blood pressure in acute ischemic stroke. As you may recall, hydralazine is a direct arterial vasodilator that's very potent in its response, and this causes a reflex sympathetic response, which increases heart rate and contractility, and also increases plasma renin activity and fluid retention. So we talked about in the setting of chronic hypertension that hydralazine often needs to be used in combination with other agents that can blunt these reflex responses. Kinetically, hydralazine has some interesting effects. It is well absorbed orally through the GI tract and then metabolized in the liver and acetylated to the inactive form of the agent. The peak effect, it does come both orally and IV. Focusing on IV therapy for this section, you can see that it has a relatively quick onset of action, and the half-life is actually pretty short, an hour. However, if you look at the clinical duration effect, this tends to be longer than the actual half-life. So clinically, the drug tends to last several hours. So again, a short onset of action with a few hour clinical duration effect makes it a useful agent for bolusing. In addition, you may remember that hydralazine has a genetic polymorphism. About half of the U.S. population is considered a fast acetylator. These patients have a lower bioavailability and also a higher rate of conversion to the inactive form of drug, so they may need higher doses. Again, we're not currently testing people for this genetic polymorphism, but if you do notice that a patient requires higher doses, it may be due to the presence of this polymorphism. Adverse effects similar to the other antihypertensives are mostly extension of the normal pharmacologic effects, such as hypotension, headache, and some of the reflex responses like tachycardia and fluid retention. One of the unique adverse effects of hydralazine is the drug-induced lupus syndrome. This, as you may remember, is dose-related, so the higher the dose, the more likely it is to occur. Typically, if you can keep a daily dose less than 300 milligrams per day, the onset of drug-induced lupus syndrome is fairly uncommon. However, patients who are at higher risk for this response are slow acetylators because remember they have more of the active drug remaining in the circulation, also women and Caucasians. The drug-induced lupus syndrome typically is reversible just by discontinuing the drug, although sometimes treatments with steroids is warranted. Clinically, hydralazine is used for both chronic hypertension, but it's also indicated for hypertensive urgency emergency. As far as where we use it for stroke specifically, like I mentioned, the IV boluses are most useful for rapid blood pressure control. And if you consider our two options for bolusing are typically hydralazine or labetalol, so when do you use which? If you have a patient with low heart rate where you would want to avoid a beta blocker, hydralazine then becomes your preferred agent. Hydralazine, again, because of the reflex responses, it's typically preferred for breakthrough hypertension as a single agent if you're going to use it chronically for maintenance therapy of hypertension. Again, remember that you usually need to combine it with other agents that are going to address the reflex tachycardia and fluid retention. The last IV agent that we'll talk about for ischemic stroke blood pressure management is nitroprusside, or the brand name is Nipride. Nitroprusside causes both arterial and venous dilation about in equal amounts, and this is due to the increase of cyclic GMP in vascular smooth muscle. Nitroprusside, if you compare it to the other agents we've talked about so far, definitely has the fastest onset of action and shortest duration. So it's given as a continuous infusion and it's rapidly titratable. One of the unique aspects of nitroprusside is metabolism. If you look at the molecule itself, nitroprusside has the nitric oxide molecule that has the clinical effects that we want, but it's also surrounded by a bunch of cyanide molecules which are toxic. One of the unique properties of nitroprusside is its metabolism. So if you look at the molecule on the right here, you can see that you've got the nitric oxide component, which causes the pharmacological effects that we want of vasodilation, but it also includes 5 cyanide ions that are toxic. So when you look at the metabolism of nipride in the body, it reacts with hemoglobin, and this forms both hemoglobin, but it also liberates those 5 cyanide ions. The cyanide then reacts with the methemoglobin to form an inert compound that's safe. Once the methemoglobin supply is saturated, the remaining cyanide radicals are converted to thiocyanate in the liver via an enzyme called rhodinase. This reaction takes a sulfur donor from thiosulfate, combines it with cyanide to create the thiocyanate molecule, which is less toxic. Most of us physiologically have enough thiosulfate to convert our cyanide into the less toxic thiocyanate molecule, as long as our nitroprusside rate is about 2 mics per kilo per minute or less. So when we look forward to therapeutics where we start to talk about doses, you'll see why we try to keep the dose lower, because this helps minimize toxicity. Thiocyanate has a half-life of about 3 days, but this half-life actually gets much longer in patients with renal dysfunction, so they would be at higher risk for toxicity. As far as the adverse effects of nitroprusside, again, most of this is due to excessive vasodilation, and this hypotension may cause reflex tachycardia, similar to what you see with hydralazine. Patients may also develop cyanide toxicity, which has a lot of neurologic effects. The treatment for this is sodium thiosulfate. Cyanide toxicity, again, is uncommon unless patients are on pretty high doses, greater than 5 mics per kilo per minute, or for more than a few days. Thiocyanate toxicity can occur, although risk factors for this are more in patients with renal disease or patients who are receiving high or prolonged doses of nitroprusside. So clinical uses of nitroprusside are for hypertensive urgency emergency, again because it's so quickly titratable, it's a very potent agent for vasodilation, it's a great drug for decreasing blood pressure in patients who have urgency or emergency. However, because of the risk for toxicity, typically this drug is limited to use for less than several days. And in patients with renal dysfunction, although it's not an absolute contraindication, you do have to be very careful about the dose and duration. And you may consider other agents as a first line before nitroprusside if possible. Patients who have acute cardiac ischemia, you may want to avoid nitroprusside due to the reflex tachycardia that could increase oxygen demand. As far as its place in therapy for stroke, again, nicardipine would probably still be the preferred agent. However, if you are unable to get blood pressure under control with the other agents we've talked about, nitroprusside is a very potent option that's typically effective if needed. You just have to be careful for toxicity. So that wraps up our review of the management of blood pressure in the acute setting of ischemic stroke. Blood pressure control in the acute period is important for optimizing cerebral blood flow. What we haven't talked about today, but which is still really important to keep in mind, is that after a patient has had a stroke, control of blood pressure is a key component of secondary prevention. since hypertension is one of the major risk factors for stroke in the first place and also for recurrence as well. For chronic management, there's also not a lot of data to identify a specific class of agents that's better than another for secondary prevention. Based on one study, it's recommended that unless patients have other compelling indications, those that have had a stroke may benefit with initial therapy with a thiazide plus or minus an ACE inhibitor if additional therapy is needed.